Good afternoon. My name is Dr. Danny Melker. Today we're going to be discussing the use of Emdogain in bone regenerative procedures. Specifically, we're going to be looking at the mesial of 22. Initially, upon probing, I found there to be an approximate 10 millimeter defect. You can also note that there is a loss of significant papilla height, as well as mesial recession and buccal recession. I also noted that there is insufficient attached tissue on the buccal, and we'll plan to do a subepithelial connective tissue graft also. When doing a flap procedure for the use of any type of bone regenerative procedure, I always like to make sure that I keep as much flap as possible to make sure that I can get primary closure. In this case, I used a number 12B blade because we were dealing with the mandibular arch. Upon reflection of the tissue, you can clearly see the large circumferential defect. I have already used an 1112 Gracie curette as well as a very thin diamond chamfer burr to smooth the root surface. I also made sure that there is no granulation tissue remaining on the bone or on the root surface, and all accretions on the root surface have been removed. Obviously, this is critical to get any type of regeneration to occur. Notice too that the periosteum is still present on the buccal. I plan, as I said, to do a connective tissue graft, and we'll use the periosteum to suture the graft in place. Because this case is about 10 years old, at the time when Emdogain came out, it also came with Pref-Gel, which is EDTA. I had no problem using a Pref-Gel, nor do I do today. You need to place the Pref-Gel on the root surface for 2 minutes to help demineralize the root surface. Also, in my cases today, I tend to use phosphoric acid 40% for 25 seconds. Whether you use the Pref-Gel or the phosphoric acid, it is crucial to rinse the root surface as best as possible to remove all of this material. I like to place a scaffolding device or material in my areas to help also hold the Emdogain in place and allow for bone to, again, move between the material and hopefully form a nice, strong, stable foundation for future maintenance. In this case, I use BioOss collagen. The beauty of BioOss collagen is that when it's put into a defect, it stays within the defect and conforms to the defect. Here I am taking the Emdogain and impregnating the BioOss collagen. I'd like to get the BioOss collagen totally 100% soaked in the Emdogain. Prior to the placement of my BioOss collagen, I have now placed the Emdogain in the circumferential defect. Because Emdogain and blood compete with each other because they're proteins, it is important to make sure that root surface is very smooth, clean, and free from any blood. If blood is in the area on the root surface, it may prevent the Emdogain from adhering to the root surface. So this is a critical part of using Emdogain. Another very nice benefit of Emdogain is that it prevents epithelial migration. What this means is we don't have to worry about a barrier to prevent the epithelium from moving quicker than getting the regenerative procedures to accommodate us. So the key here will be no need for the use of a barrier. I have now placed the BioOss collagen in place. You'll notice how beautifully it conforms to the defect. I can pretty much tell you that when you put it in this way, it will stay there. But it's always great, as I said, to have primary closure. Because I was able to preserve the periosteum, I've been able to place a connective tissue graft on the bone connected to the periosteum. The reason I like to place connective tissue grafts is because we all know that connective tissue is dense, thick, and somewhat avascular. It acts as a protective mechanism to the underlying periodontium and prevents bacterial infiltration. So if we're going to, in effect, create a total ideal environment, we want to add connective tissue at this point in time. As you can see from the photograph on the right, the case has been totally sutured back and the papillas meet, thus getting primary closure. I think it's critical for all of us that do bone regenerative procedures to try to get primary closure and prevent any secondary healing. You can see clearly that the area is smooth, clean, and we should have a nice environment for possible regeneration to occur. We are going to now proceed to an actual case. This case presented to me several years ago. The patient was from California. He was referred to me with a large periodontal abscess on tooth number 12. I find treating bicuspids to be most difficult if I cannot gain vertical access. So in essence, in looking at the case, I think we would all agree that removing the calculus is critical, but if we could remove the concavity present, that would be even a better benefit. So what I did was work with the long diamond burrs, thin diamond burrs, and remove the mesial buccal and mesiolingual line angles of the concavity. I did not work on the concavity to start with. The area in mind was to smooth the adjacent line angles, thus doing away with the concavity. Here is the actual probing, so you can tell from where we are. We were probably talking about an 8 to 10 millimeter defect. And intraosseous, it was a two-wall defect, about 5 millimeters of loss of bone at this point in time, with obviously previous bone already being lost. After spending a good half hour, I was able to remove the mesiobuccal line angle as well as the mesiolingual line angle. What this means is that floss will work and a curette will work. I then went in and smoothed any remaining calculus from the concavity, or furrow if you want to call it, from the mesial number 12. So the root surface was cleaned totally, and then we placed our Emdogain, BioOss, Collagen in the area. The patient returned, and you can see a mild amount of calculus on the mesial, and this is approximately 3 months later. We're cosmetically able to keep a result that was within reason, because if you consider where the original bone loss was, we certainly could have ended up with a major issue. Upon probing, I was pleased to find only a 3 millimeter area, and also if you'll notice there is blanching of the tissue, so you know that we were probing significantly to find out how deep the defect or sulcus really was. There was absolutely no bleeding at the time of probing. However, when we truly look at the x-rays, we need to be critical. The x-ray on the left shows a defect before we placed any BioOss, Collagen, or Emdogain. At this point in time, we can see really that the BioOss Collagen has not integrated with the surrounding bone. Again, this is only 3 months later, but to say that we have a success would be not correct. At about a year, I would like to see on the radiograph the BioOss Collagen gone and what appears to be radiographically new bone or regenerated bone. Certainly what I like to do is open an area up and see what basically we truly have. So what we're going to do is, in the next couple of slides, show you several cases that I treated back in the late 1990s when Emdogain came out, and the before and after. Back when I first started using Emdogain, I explained to all my patients that if we were going to see truly if the Emdogain was a benefit, we would need to re-enter the area in a small way at about a year. I had very little patient objection to this because they truly wanted to know what they were paying for also. At this point in time, we're looking probably at around 1998, 1999. The area is reflected between 14 and 15, and we have a defect that approaches 8 to 10 millimeters, and there's only 2 walls remaining. During my early use of Emdogain, I also used freeze-dried demineralized bone as my scaffolding device. So what was placed in this area was Emdogain and freeze-dried demineralized bone. The area opened up about a year later clearly shows a very decreased probing depth. We can't say that is bone because we didn't take any histology, but it doesn't probe, and I can tell you it is attached to the distal of 14 and mesial of 15, and no probing occurs. So we went from a significant loss of bone to what appears to be a very healthy area at this point in time. The next case is the lingual of tooth number 14. You can clearly see the concavity that exists or defect in the bone. Again, I used Emdogain and freeze-dried demineralized bone. Upon reflection of the flap a year later, it was clearly shown that what appeared to be bone had filled in the defect. I state to you clearly that I don't know that this is bone, but it certainly acts and has adapted to the adjacent bone as if it was bone. There was no probing or bleeding when I did do the initial probing depth evaluation. This patient was treated approximately 10 to 12 years ago. The defect between tooth number 26 and 27 approached 8 to 10 millimeters again, and there was no bone or very little bone on the mesial of 27 and distal of 26. This was a two-walled defect. We used Emdogain as well as freeze-dried demineralized bone. Upon reflection of the flap a year later, I found there to be what appeared to be bone and virtually no probing. Fortunately, this patient returned to me just a couple of months ago, and I was able to do a small reflective flap to find that in fact what appeared to be bone was still in place and had not degraded back to having a defect. My main reason for treating the patient was because of the crowded teeth, and I want to say initially he did not want to undergo orthodontics. He did get some granulation tissue between the crowded teeth, and you can see the major root proximity issues between 25 and 26. So I was able to get a nice photograph 12 years later. Upon opening up the 22-23 area, it was almost identical to the 26-27 area. We were dealing with a two-walled defect with significant bone loss on the mesial of 22 and on the distal of 23. Upon reflection of the flap a year later, you can clearly see what appears to be bone is present, and it certainly appears as if it has adapted to the bone which was originally there. No probing was exhibited, and again, the depth initially was in the 2 to 3 range with no bleeding. Now the question may come about, why are the colors of these slides so unusual? The reason being is back in the 2000 era, we used Kodachrome film, and in order to go to digital, we had to change our slides to digital, and in doing so, many times the colors did change. But what is beautiful, as again here, you can see recently in 2012, from say 2000 to 2012, we have a beautiful result with again what appears to be bone totally filling in a defect, and you can almost say that it has in fact moved more coronally as time has occurred. This is simply a clinical observation and cannot be at all taken as fact. So today we've been able to look at a way to do bone regenerative procedures that is very simple, and we use in fact Emdogain, which hopefully will stimulate bone regeneration, and a scaffolding device that I now use is BioOss Collagen. Hopefully this has given you enough information that you can at least consider this option. Also, again, one of the biggest factors in using Emdogain is it prevents epithelial migration, which removes the need for any type of barrier. I appreciate your time and have a good day.